5 components of an arterial blood gas. pH is to look at the acid-base balance. PaCO2 is to look at the ventilatory status. Bicarbonated for the metabolic status, predominantly from renal perspectives. PaO2 and SaO2 are the partial pressure and the oxygen saturations. And base excess is to look at the overall acid-base reserve in the body. Clinical indications to do an ABG, obviously whenever you're worried about the respiratory drive or the ventilatory drive, so whenever there is oxygenation or CO2 problems, altered mental status due to hypoxia, hypercapnia, when you're worried about the acid-base status due to any reasons, DKA, sepsis, etc., in ventilated patients, and also when you want to titrate oxygen therapy. Otherwise, the VBG is good enough, but if you are worried about oxygenation in COPD, then ABG is a gold standard. So metabolic acidosis, anything which drops the pH, and bicarbonate, which is a buffer, bicarbonate buffer, and the basic buffer, if that's low, that's a primary metabolic acidosis. And in carbon dioxide, if it's low, that's an acidic gas. That means there is a compensatory response. So examples of the metabolic acidosis: DKA, lactic acidosis, renal failure. Remember all those mud piles. Respiratory acidosis, once again, pH will be low, which indicates acidosis. And the partial pressure of CO2 will be high because it's an acidic gas, so hence it will corroborate by going higher, which means there is respiratory acidosis. The compensation obviously from bicarb, which is a buffer, will be opposite. So bicarb will be raised because again in acidosis the body is trying to compensate for it. Examples include COPD, sedation, any neuromuscular disorder. Metabolic alkalosis, pH will be above 7.45, hence alkalosis. The bicarb will be quite high. Again, it's a metabolic component, so you would expect for the primary metabolic alkalosis for the bicarb to be high. And CO2 is an acidic gas, so it should be it should be high because it's trying to compensate by increasing the acidic component in the blood. So the common examples include severe vomiting and diuretics and also hyperaldosteronism. Finally, respiratory alkalosis, again pH will be high, above 7.45, because it's respiratory, so we would expect the respiratory component to corroborate with a change in the pH. So if the change is alkalosis, the acidic gas should be blown off by the body. Hence, the CO2 will be low, PaCO2 will be low, which would indicate primary respiratory alkalosis. The compensation in terms of the acidic component or the buffer component to counter the alkalosis would be to reduce the bicarb so that the acidic component is compensating for this alkalosis. So hence the bicarbonate will be low. Examples include hyperventilation in terms of anxiety, pulmonary embolism because you're trying to compensate for hypoxia, high altitude and early sepsis.